Hello and welcome to Stewards of Stem Cell and Kidney Transplantation, the critical role of pharmacists in staving off CMV infection. This CMO snack activity is supported by an educational grant from Merck. I'm Dr. Genoveva Papanikolaou. I'm an attending physician in the Infectious Disease Service at Memorial Sloan Kettering Cancer Center and professor of medicine at Weill Cornell Medical College. I'm very pleased to be joined by my colleague, Dr. Andrew Lin, a clinical pharmacy manager with the Adult Bone Marrow Transplantation and Cellular Therapy Services at MSK. Welcome, Dr. Lin.
Thank you, Xenia. A pleasure to be here.
Here are our learning objectives for today. After this activity, learners should be able to discuss the role of pharmacists in managing CMV associated with kidney and stem cell transplantation. First, let me set the stage for today's conversation. CMV is a very common viral pathogen in the transplant population and is associated with significant morbidity and mortality. In general, there have been two strategies to manage CMV. The first is prevention strategy, and the second is preemptive therapy. The first strategy aims to prevent any CMV replication, and the second strategy, the preemptive therapy, therapy is instituted when there is active CMV replication with the goal of preventing CMV disease. Now, in terms of definition, CMV infection, for the purposes of this talk, is active CMV replication in the blood or tissues. A CMV disease is clinical signs and symptoms with involvement of one or more organs. And typically we call refractory CMV infections those that progress despite appropriately dosed antiviral therapy for at least 2 weeks, and resistant those cases that are refractory to treatment and also have associated mutations that confer resistance to specific antivirals. So, Andrew, can you talk to us about our antiviral armamentarium for CMV?
Sure. We have our conventional agents, which most people are probably more familiar with. So ganciclovir and the oral analog valganciclovir, foscarnet, and cidofovir. These all have several limitations that prevent them from being used for prophylaxis and why they're reserved for preemptive therapy. So bone marrow suppression, renal toxicity, electrolyte disturbances, and then most of these are IV, other than the valganciclovir, which limits their administration to in the hospital or clinic with home infusion as a possibility. And toxicities are just a big limitation of those. And then we have our newer, more novel agents that have been still somewhat recently approved. We have maribavir, which is for refractory CMV infection, which is resistant or just toxicity prevents utilization of the conventional agents. And then we have letermovir, which is the only agent that's approved for prevention of CMV infection for stem cell transplant, at least. Although in the renal solid organ transplant, their valganciclovir and ganciclovir have been used.
And what are the mechanism of actions of these antivirals, and how do the newer antivirals differ in their mechanism of action compared to the well-established antivirals that we have been using for treatment?
Sure. Our more conventional agents, like the ganciclovir and valganciclovir, for example, they have to be phosphorylated to be incorporated to inhibit DNA polymerases, so to halt CMV replication. Cidofovir works similarly and is also phosphorylated, and foscarnet will directly inhibit those DNA and RNA polymerases. Whereas letermovir has a unique pathway of its mechanism of action. It's more virus specific, and it doesn't cover any of the other viruses that we're so worried about during transplant. But it does exert its pathway of mechanism of action by directly inhibiting the terminase complex, so a little bit further downstream and more virus specific, which is probably why there's a little bit less side effect with that utilization.
Great. Moving on, as the title of this program indicates, we are going to focus on the pharmacists, your role in staving off CMV infection with the novel antivirals. But first, could you actually give us a few examples of what you and other transplantation pharmacists do across the spectrum of care in a contemporary and well-resourced center?
Sure. We're involved really from the start all the way through the whole transplant process. I think that's the benefit of getting your care at these larger centers. So even pre-transplant, we help with the decision making of um, identifying which patients are most appropriate, what regimens might be appropriate for their conditioning, and then all the supportive care that goes along with that. And we'll go over the education with the patients so they have a general idea of what the new burden of all the medications will be from their immunosuppression and all the prophylaxis that we need to do. We'll manage their current medications and help select what can be continued or what has to be substituted during the course of their transplant admissions, or if they're if we treat them in the outpatient center, same thing. Whether we have to interrupt. Then during the whole transplant course, it's more of the same daily assessments um, of their medication regimens to make sure that everything is appropriate, everything starts on time, that their side effects are managed, and that we are treating patients as effectively as possible. And that includes rounding and seeing the patients with the team. And then post-transplant, we're still involved. We still have to manage all the complications that come afterwards, and we help. We're sort of the keepers of the guidelines. We help make sure we don't bother you guys too much on the ID service, and we are the ones who help remember the durations of therapies or the other considerations for when we need to interrupt or other things we need to consider as we're doing getting patients through the transplant process.
Great. And in terms of stewardship, are you involved in some quality research or in ensuring best outcomes?
Yeah, actually, I think that's another unique aspect of our job description here at MSK, that we have the availability to conduct research. We have the resources that are part of the transplant service as a whole, so we have access to those as well. So we've actually done quite a bit of research in trying to look at real world outcomes and using letermovir. We were some of the first, we were an early adopter, and we had one of the biggest early experiences with using it for prophylaxis. So we had the extended duration even before extended duration became a thing. We have secondary prophylaxis data as well, cost efficacy, all sorts of, and drug interaction analysis as well. So those are all some of the different aspects that we've looked at to try to optimize care in collaboration with the rest of the transplant and ID services.
Great, and that's a good segue in to talk about CMV prevention with letermovir. So as we are all aware, letermovir was approved by the FDA for CMV prevention first in the end of 2017 for CMV seropositive recipients, stem cell transplant recipients, and more recently in 2023 for prevention of CMV in donor-positive recipient-negative kidney transplant recipients. Can you talk to us a little bit about your experience of what was the burden of CMV before the adoption of prophylaxis, specifically for the stem cell transplants? How frequent it was, and what were the problems that you encountered?
Yeah, I think generally speaking, if you look at all transplants across all centers, the incidence of CMV reactivation is somewhere in the realm of 60+%. I think we at our center we do a lot of high risk transplants, or those that are high risk for CMV reactivation. So the CD34 selected or T cell depleted, the cord bloods, and now the haplos and PTCy based transplants. We are at the forefront of using all of these things. So we do see a lot of high risk patients, and those patients are some of the reactivation rates. If you look at cords, it's 60 to 100% depending on what you look at for the study. So we know that a lot of our patients require therapy. If you look at in the literature, there are probably 60 to 70 or 80% again of patients who require preemptive therapy, which is where we monitor and treat when patients reach certain thresholds. And despite that, we were still seeing CME disease in the preemptive therapy era, probably in the realm of 10 to 50%, depending on the type of transplant. So we were seeing patients have toxicity from the infection itself, as well as um, a lot of toxicity from the treatments we were giving, which we were doing a lot of before.
Right, right. And I still remember the old days of having frequent administration of foscarnet, several patients every day coming to clinic and spending many days with intravenous infusions. So let's talk a little bit about in the prevention era. We know, of course, that letermovir was approved initially for the first 100 days after transplant. Can you briefly walk us through the most recent study? What are the main findings of the extended duration prophylaxis study when prophylaxis was extended from 100 days to 200 days in stem cell transplants?
Sure. So this was a randomized multicenter study that looked at patients who are at high risk for CMV infection or disease, and they randomized them before the day 100 mark to receive another additional 100 days, so out to day 200, or to stop and get a placebo for those extra 100 days of letermovir prophylaxis. And the main endpoint that they looked at was clinically significant CMV infection, which is the composite endpoint that we've looked at more recently for a lot of these CMV trials. So that's CMV infection requiring treatment and or a CMV disease. And it was, as we would expect, effective in preventing CMV disease while you're on letermovir. We It dropped it somewhere from like 20 to 2% or something like that off the top of my head, I think. So it was effective while you were on it, but it did still see some reactivation in the time after discontinuation. So there's still some work to be done in determining who could safely come off, or is there something different that how do we predict who might benefit from this extra prophylaxis, even in the high risk patients. But that's sort of the main thing that we saw in that study.
Right, and just to mention that in terms of safety, there were no new safety concerns. Letermovir, even when given for 6 months, was equally safe as when it's given for 100 days.
Right.
Now,
That
yeah.
Oh, sorry. That's very in line with like our own studies, right? That you and I did. We had basically no one ever discontinued it for any drug-related adverse event as well during in our personal experience as well.
Exactly. And I wanted to dive a little bit deeper in your personal experience, as you mentioned that we've been using letermovir for 6 months or longer for quite some time now. Can you share some of the findings in terms of rebound CMV in high-risk patients after stopping letermovir at 6 months?
Sure. Um, the most recent study that we did that looked at this was in a subset of patients, just particularly those that received post-transplant cyclophosphamide as prophylaxis. So we expanded it from not just the haplotransplants to the match-related and unrelated donor subsets. So those are all included in our most recent study that was published at the end of last year in Blood Advances. What we found was that um, it's there was still a high rate of CMV, clinically significant CMV infection occurring after letermovir discontinuation. The median time was about that 6 month mark that we had discussed before, but some were earlier and some were longer. The interesting thing was that we couldn't find many predictors of who would have a good outcome, like not have CMV infection in those 90 days after discontinuation, for many of the things that you would expect. So their CD4 count, their the timing actually didn't matter, whether it was before or after that, the straight time mark that would this most recent study that we discussed previously, that didn't pan out. But the only parameter that we could find that perhaps is predictive was whether patients had resolve their hypogammaglobulinemia that can happen after transplant. So if they had an IgG level that was in the normal range unsupported, then they were less likely to have CMV reactivation. Also, those who didn't receive as intensive a preparative regimen, those who got the non-myeloablative preps, they basically none of them reactivated after we stopped it after the extended duration. So those are the two things that we found, and we're trying to replicate to see if that will hold up in other settings as well.
Great, and you're touching a very hot topic, what adjunct tests could be helping us in determining who is at risk of rebound infection. And particularly there's an emphasis these days on the cell-mediated immunity assays. For example, the extended duration study used as an exploratory endpoint used quantiferon, CMV quantiferon test to see if quantiferon could predict who would reactivate after stopping letermovir either at 100 days and at 200 days. And preliminary results from this study indicate that patients who had positive quantiferon were much less likely to reactivate, but among those with negative quantiferon, it was 50-50. 50% would reactivate, but 50% would not reactivate. So a value of a negative quantiferon was not predictive of CMV reactivation. Now let's move on. I know that recently there was Dr. So and the stewardship program published some data from Sloan Kettering on the costs of extending prophylaxis up to 180 days for high-risk patients. Can you talk to us a little bit about that?
Oh yeah. So Dr. So worked with Carrie Tan, our old ID resident, and Lauren Derspers, or Palin, her married name, who is still working with us. They looked at the day 180 cost of letermovir versus the average cost of preemptive therapy in the preemptive therapy era. We looked at matched patients, the same types of patients, looked at divided them between high risk and standard risk by the usual criteria. So the T-cell depletids, cords. Actually, I think cords were excluded in this study. Is that right?
Yeah.
And the haplos, the PT size, those who had GVHD versus our standard risk patients. And both subsets actually had lower overall costs with letermovir through the 6-month mark compared to preemptive therapy. But in the high risk patients, it was statistically significantly less. I think the average cost was less than half of what it would be in the preemptive therapy era, compared to like 44 versus 60,000, which was not statistically significant in the standard risk CMV patients.
Right, so it seems that despite the added cost of providing a letermovir for 100 days in the high-risk patients, there was still savings in the inpatient and outpatient costs. And the bigger savings was really for the first 100 days post-transplant, but remained significant up to 180 days post-transplant for the high-risk patients.
Yeah.
So let's dive a little bit into your daily work, how you, in the real world, we manage patients, you decide when to stop. And I'd like also to see if you could talk to us a little bit about interactions of letermovir with other medications.
Sure. So we're very involved in screening our patients for drug interactions and managing these interactions as they come. So letermovir is a substrate of 3A4 and PGP, and so that's a major metabolism pathway for many drugs. So there are a number of medications that come up as having interactions with letermovir. Um, we did an analysis looking at immunosuppression levels and letermovir, and in our findings, there was not a significant interaction, but many other centers have found that there is. And I've thought more about it in the year since we did the analysis, and I think it's probably that there is an interaction, but we use it in combination routinely with azoles, and we start them at the same time, basically at day 7 in our high-risk patients, or around the same time at least. So I think it's probably being masked by a concomitant moderate to strong 3A4 inhibitor. But in the solid organ transplant setting and like a kidney transplant, they're probably not on nasal. So it seems like it's probably a more significant interaction to watch out for there. Also, I've seen a lot of patients who, as we're tapering them off their immune suppression, we need to be mindful, especially of those who are on cyclosporin, to increase their letermovir if they require continued prophylaxis. Like if they're still on steroids, but they're coming off the cyclosporin for other toxicity reasons, then they need to remember to increase to the higher dose since that interaction will go away. And then when it comes to stopping, I think it's a collaborative decision between the providers, the patients, and us. We can't just let the patient stop it just because they want to, but very often there is financial toxicity despite the cost benefit overall for the patients to be on the Termavir. Like we before in the last several years, we've gotten a lot more help from our patient financial services to help coordinate care and arrange for patient assistance and enrollment and manufacturer assistance, that sort of thing. But not everybody is eligible, and not everybody can enroll in it, and it's still tricky. So that's sometimes a consideration for having patients come off if they've reached somewhere after the 100-day mark, and we're like, well, if it's too expensive, it's very reasonable to come off. We can monitor. It's okay. Or if they reach these benchmarks that we've seen, like they have a good IgG level, their counts are good, they're not on immune suppression. It's like, well, you're just continuing it because you've not thought about it sometimes. So we help remember when we should help patients come off.
Right, and that's a very important point that we have to balance the administering the medication versus the toxicities in general, financial and other the pill burden, and
Yeah.
etc. And can you give us a little bit of more information on access in general? Have you had problems obtaining Letermovir for your patients? How have pharmacists enabled access, etc.?
Yeah. So I would say that it's probably been improving over time as we've gotten used to having payers see that letermovir is beneficial, and it's been improved now for several years. But um, some of our colleagues, Stephen Ng and Greshma Vadakal, they did a study looking at the financial burden of transplant overall, so looking at high-cost medications, and letermovir was one of the medications that came up very often. So about half of patients had very high costs, over $1,000 per fill, at least for their initial fill. And actually, over half, the vast majority had at least moderate to extensive financial barriers in obtaining letermovir. I think in that study, almost all of them required some sort of financial assistance, but a lot of times it was like the copay assistance card, the manufacturer assistance card, or direct um, drug from the manufacturer, or hospital provided financial assistance was also available for some. But the piece that I found more striking as a pharmacist is that the coordination of time required on average for pharmacists was over the max of 60 minutes that's documented. So um, if there was a median, it's 100%. It's all the time that we could possibly give. So I think that's something that has been improving, but is something that pharmacists are unfortunately or fortunately very involved in.
Right, right. And it may be a bigger issue in centers with less resources and less pharmacists to share that burden.
Yeah, for sure.
So let us talk a little bit about a topic that is dear to me, and I know it's of great interest. How about Letermovir in the pediatric patients?
Yeah, I think, it's I don't practice directly in pediatrics, but our colleagues do touch base with us very often. I think they are routinely using it in their older pediatric patients. I think those that are 12 and up have routinely seen prophylaxis with the Termavir off-label now for the last year, 2 years. Um, I think you know a little bit more about the dosing than I do, probably though.
So yeah, that is correct. So we've been using for a while now the adult doses in adolescent patients, so those that are 12 or older. And we've actually have gone down to using it even in younger patients based on the doses that were used in the phase 2 pediatric study. The good news is that the pediatric dosology is going to be expected to become available, approved by the FDA, the third quarter of 2024. So hopefully we will have not only the doses, which has been a little tricky for the very young kids, but also the formulation, right? Because little kids cannot swallow pills, so there was going to be some different type of formulation, granules or sachets or something else. And that will be, I think, a major advancement for the care of pediatric stem cell transplants and in general transplant patients.
Yeah, I know my colleagues in the pediatric world will be very happy to not have to crush and figure out how to dilute and make suspensions ad hoc. So I think it'll be a good thing for sure.
Right. I think our time has come to close to an end. Is there something additional that you would like us to mention? Anything in the pipeline? Any anticipated changes?
Um, Nothing in particular. I think it's really important that we've talked about prevention, but I think we still see some resistant CMV still. So I think maribavir is an important thing to remember. There are also investigational agents that we sometimes still have to pull out of our hat. So I think pharmacists need to be aware and help coordinate those as they come as well. But I think, there's not many things that we do that we know can have a mortality benefit, and I think preventing CMV is one of them. So I think it's a very important piece of what we do.
Great. Well, we are just about out of time. I'd like to thank Dr. Andrew Lin for his astute insights into the world of transplant pharmacists. And I thank you, our audience, for participating. By the way of a summary, I'd like to offer 3 SMART goals. SMART stands for specific, measurable, attainable, relevant, and timely. So be vigilant for CMV infection and disease in solid and stem cell transplant patients. Recognize the multifaceted role of the transplantation pharmacist in preventing CMV infection and disease, and scale relevant experience from large centers to centers with varying resources. Finally, implement strategies to prevent CMV infection in transplant patients that include the appropriate use of novel antivirals. To receive credit for this activity, participants must complete the post-test and evaluation online. Participants will be able to download and print their certificate immediately upon completion. Thank you again, and that concludes our program for today.